good evening, everybody. Thank you for joining me again. This is Dr. Stephen Walker, broadcasting live on Twitter, Facebook, and YouTube, waiting for LinkedIn to approve my broadcasting license. But anyway, we're here tonight and every Tuesday and Thursday night discussing mental health topics. Got a great guest tonight. We got Dr. Khalid Bawarshi. He owns a TMS clinic in Florida, and he's going to explain what TMS is and how that works to treat depression. So what we're going to do is we're going to have him come on in a second. Here's his website. You can check him out if you're in Florida or if you want to fly to sunny Florida and get some treatment. But remember, these mental health live streams are for you, are for the viewer. Hey, Penny, how are you? Melissa's back. Yeah, Melissa's in the house. Welcome back. Sham, what's up? Good to see you. Never saw you here before, but thank you for logging on. So what I'm going to do, we're doing something a little different where before I would talk about something and then cut away to questions, cut away. And the feedback I was getting from some people was it was a little confusing. So we're gonna talk for about, I don't know, 20, 30 minutes. We're going to engage with Dr. Khalid about a bunch of different things. Keep your questions coming, keep your comments coming. And then we're gonna, after about 30 or 40 minutes, we're gonna get to your questions and talk about that. Okay, so let me go ahead. Again, thank you for everybody for logging on tonight. Remember, we need to engage and talk about our mental illness. Why? Because we all have a degree of mental illness. I do. I'm sure Dr. Khalid has his own degree he's working on. We all have it. There's nothing to be ashamed of. We all have a degree of physical health, physical illness. We all have a degree of mental illness. There is absolutely nothing wrong with talking about it. Okay, so let's go ahead and bring on Dr. Khalid. I call him that, but you can call him Dr.
Hi, Dr. Walker.
Bawarshi. What's up? Hi, how are you? Thanks for joining. I know this is late. Dr. Khalid had to make a special trip back to his office just for this. So thank you for coming. So let's talk about it. What's going on with this TMS treatment? I mean, you know, we see a lot of maybe people are even not even aware of it. So I know it has something to do with magnetic fields and your neurons and depression. So why don't you walk our viewers and people watching this through what is TMS? What does it do?
Absolutely. I don't want to miss the chance though in the beginning to thank you sincerely for having me, talking with your audience. And I want to thank you, sincerely as well for doing what you're doing. Obviously, trying to spread, awareness of mental health issues is very important.
It is because, people don't talk about it and they suffer in silence for years thinking, oh, I've got to be depressed and anxious the rest of my life. And that just isn't the case. There's so many treatment modalities out there. So yeah, tell us what is TMS or you can talk about your background or wherever you want to go.
Sure. So understanding TMS, we have to look a little bit more about mental health and what depression is, how we treat depression, and take it slightly from there to understand why we're looking outside the typical norms of antidepressants medications to kind of see other solutions for treatment of depression. And that speaks to, the mission of what you're doing, which is really important, which is normalizing the talk about mental health generally. So that is a cause that we need to push more and forwards over time. And we as doctors, in the medical field should be participating to that as well. I should be, the physical illness should not be different than medical and then mental illness, to physicians.
Exactly.
It usually serves me the example of when people trying to understand, heart disease, for example, and how this could be similar or different than depression. Technically, it's not really different,
What do you mean by that?
Well, so say if a patient has a heart attack and the cardiologist is admitting them to the hospital to put a stent in their heart, and then the patient, after they get their treatment, they ask the doctor, so what caused my heart attack? Was it because I received the bad news yesterday? More likely, the cardiologist would say, not necessarily. It's multifactorial. You have your genetics, so some families do have heart disease more than others. Then you have the way that you lived your life. This is your lifestyle. So, if you're eating junk food and, not watching salt in your diet, not exercising, living a lifestyle that is not cardiac healthy. And then on top of that, you have the immediate stress that you had. Then when you have those three ducks in the row, then that's how you get heart disease. Well, that's not really different than mental health, right?
Exactly, because
So
you're
when
eating
somebody,
thoughts all day long,
Mhm.
and you're stressed, and you're
Absolutely,
worried about things, and you're keeping
absolutely.
all those wounds, those unhealed emotional wounds in.
Right. So when my patient says, "Is it my divorce last year that caused my clinical depression?" I usually answer, not necessarily. It's a contributing factor, but there are genetics. Some families do have depression more than
Hmm.
others. Some families do have incidents of suicide more than others. And then there is the way that you were raised. When this brain was forming,
Conditioning,
when you were
baby,
a little child,
conditioning.
that's when our brain is building circuits and understanding the safety of the world around it and how to comprehend thoughts, how to comprehend, events around us and how to behave in response to those. And then there is the stress that you've been living here recently. So
Hmm.
the stress that you've been living in recently could be the most recent trigger, but it's not the complete reason for your depression. And that's an important factor there. Why? Because then it would be easier for this patient to talk about their depression.
Hmm.
It would be more acceptable for this patient to seek treatment for their depression. And it would be also easier for the treater, for the mental health provider, to take that illness and attack it from all aspects of it.
Hmm.
So it's not only medications. Medications is going to help with what's going on with the brain organically, but
Sure,
also
sure.
therapy
Like a
would be.
painkiller, it reduces the pain, and then you can get the treatment in there.
Mhm. So if we borrow the example from the cardiologist again, from the heart doctor is going to put a stent in this heart, and he's going to prescribe multiple medications, and he's going to advise the patient to do lifestyle modifications. He wants you to quit smoking, he wants you to exercise, he wants you to watch your diet, right? Similar thing with depression. So if we have
Hmm.
clinical depression, yes, we might need to use medications. They're sometimes effective, they're sometimes not effective. They could be dangerous if they're misused, right? And
Hmm.
also we need to do psychotherapy and we need to decrease stress around us, right? So
Absolutely.
all aspects together will get us where we need to be. So how big
Exactly.
is depression?
And it's
Yeah,
good that you and I are, because there is a lot of people don't know, there is some tension between psychiatrists and psychologists in the field. So, that doesn't need to be there. There doesn't need to be a competition of who's right or who's wrong. It's about we're all on the same team.
it is as much of a tension that you could see between doctors and pharmacists, right?
Exactly.
We
Exactly.
are all there, trying to help the patient achieve what they want. If I am a physical therapist and a neurologist, right? A neurologist diagnosed a stroke, but then he would need the physical therapist to help us, rehab this patient to they gain some function of their muscle.
Exactly.
My
Exactly.
medicine as a neurologist is not, if I were to be a neurologist, my medicine as a neurologist is not going to get that function back. I need the help from the physical therapist. So it's a
Bingo.
collaborative work, and the aim at the end of the day is the improving quality of life of the patient. So
Exactly.
when we have this picture in our mind, absolutely it would be integrative care, all the way around. So if we were to talk about depression a little bit so we can understand TMS, I'm going to share with you a slide or two in here. Let me see if I can get that up here. So how common is mental health? You just said, everybody has a little bit of a mental health issues, right? Well, that if we're talking about depression as a feeling, I could feel depressed right
Sure.
now. That
Sure.
doesn't translate necessarily to clinical depression. But
Exactly.
clinical depression itself is pretty prevalent. About 1 in 5 Americans will get depressed at some
And
point.
feeling bad and feeling down is even more prevalent, so.
Correct. So we have to distinguish between clinical depression. This is when we meet, 5 out of 9 criteria for depression for at least 2 weeks. That is affecting someone's life. Then we diagnose clinical depression. That could be different than if we're saying somebody has adjustment disorder. So adjustment disorder is that person who's having a little bit of shortness of breath when they're running, but they don't really have heart disease, right?
And just so people know, an adjustment disorder is there somebody is having an adjustment issue with dealing with something in their life. So they're having a disordered reaction to some traumatic event in their life.
Yeah. And it could exhibit itself similar to depression, but it usually would be in a shorter period of time, and it would be less intense than clinical depression.
Exactly.
Now, if we're looking at clinical depression, 8.3% of the US population get depressed every year, right?
Wow.
So you will have a couple of weeks taken
A
away.
lot of people, man.
Mhm. Those are 2 weeks taken away from your life, from the quality of life that you have, or from the productivity and what have you. Obviously, COVID did not make things better, right? So there is this talk about, depressive symptoms multiplying threefolds, in the year or in the time after COVID compared to before COVID. And there's even this discussion now of whether there is a neurological involvement with the virus itself. Like, does it go into your CNS, your nervous system, and does it cause, encephalitis that could result into depression and anxiety after? Just like how Lyme disease or EPV or CMV, those kind of infections could lead to depression after the infection. That's something to unfold, over time. It's disabling. I'll show you a slide after this one. You would see that depression is basically the number one disabling disorder in the world, according to the World Health Organization. And that could be, strange in the beginning. We always think that cardiovascular disease are disabling. And cardiovascular disease are the number one cause of mortality in the US still. And we're not talking about mortality. We're talking about disability.
And we still don't really know the connection between our thoughts and emotions and how our body heals,
So we're talking about how much time we're losing and how much productivity and quality of life we're losing. We would lose more of depression than we would lose of heart disease. I'm going to pour the example one more time. Somebody has a heart attack, they end up in the hospital, they get a stent in their heart, they take their medication, they're back to work in a couple of weeks, right? If somebody get depressed and they were suicidal and they get admitted to a hospital, recovery takes longer. That therapy, that rehab, that getting back into life takes a little bit longer. So it's a little bit more disabling. And when it comes to treatment, we can help a lot of patients with psychotherapy. We get about 50% of them better. That's what you do on daily basis, right? And we help even better number of patients if they do both medications and psychotherapy for selected cases. Not everybody needs medications,
exactly.
By the way, I have to be very clear in here. Mild to moderate depression, first-line treatment is psychotherapy, not medications. Okay.
A lot of people don't even know that.
I know. And the talk about why we push for medications is so big. I don't think we can cut it in this hour.
I know, exactly.
We in the future might talk about it a little
because
bit.
I'd love to hear how you feel about general practitioners with no mental health training, antidepressants and anxiolytics. I mean, but that's a whole nother conversation. So
let's throw a quiz for your audience. See who can get this question correct. What do you think is the specialty? What subspecialty of doctors prescribe antidepressants the most? What specialty they are.
I'll give you an initial. I'll give you the initials. It's one is G and one is P.
They're going to say psychiatry, but
exactly. No, hell no. And then, anyway, we can go off on this, but then you got PAs and you got nurse practitioners and NODA here. It's not psychiatrists; it's general practitioners.
Yeah. All right, so. Basically, even when we try with our best, to do psychotherapy and medications, we still miss about 20 to 30% of patients who are suffering from depression. And that's called treatment-resistant depression, okay? So treatment-resistant depression is a big deal. That is when, this is the hidden disorder in our society that we are somewhat given up on. And I don't want to sound, kind of dark in this regard, and I hopefully this doesn't get interpreted this way, but you could see how much we're letting down our patients somehow, because see what happened with COVID, in a year when everything is frozen because of what happened with COVID-19, we put trillions of dollars into figuring out a solution to the problem. We put all the scientists that we know into this task. And we figured out there is a new way of doing vaccines now, because we wanted to solve the problem, right? So imagine if tenths of this effort is put into mental health, right? What could happen then, right? Could we solve this problem with treatment-resistant depression that nobody is able to figure out? Could we save those 17,000 people who end their life every year in the United States of America? These are folks who we care for,
and so many of those are so needless. It's like. The thing that, breaks my heart doing this work is there's so many people that can be helped with these negative thoughts and emotions, but they're in that hopeless hole. And when you're in that hopeless hole, there's no hope. I'm sorry, but keep going.
And that's why I appreciate what you're doing, because you're helping, though it's a small step, but it's a step worthy noticing that you're raising awareness. So people would be feeling more comfortable talking about these things. Everybody is comfortable talking about COVID-19, whether they understand it or not. Why?
Or their acid reflux or whatever.
Or acid
Or
reflux.
male pattern baldness, right?
Absolutely. Or even their acne, even things that are, used to be stigma in the past, or people would be worried talking about it, they're kind of cool about it nowadays.
Bingo.
Why are we behind on mental health? So let's, speaking of disability, let's just see, one of the studies that was, I think, published in Lancet's Global Health, comparing the disability that we observe in patients compared to other medical illnesses. So depression is split into two parts in here. If we're talking about moderate depression versus severe depression. Severe depression is when we get to the suicidal thoughts, right? This is when your patient is, not living, basically, not functioning in their life. And it's basically in between the moderate and severe. It sandwiches in between heart attack and cancer. So severe depression is more disabling than cancer and heart attacks, right?
Wow.
Moderate depression might be on par with heart attack, kind of a little bit less than that. But this is how disabling depression is. So again, speaks to how important this is, as of a treatment, as of a disorder that requires immediate treatment, okay? And then now, let me see if I can make this larger. Okay, hopefully it's easier to read this way. So in this graph, I would tell you what we do currently for the treatment of depression. So the first line, as we talked about, is psychotherapy. So if we do monotherapy with psychotherapy, we can get close to 50% of patients better. So this is good, okay?
Now, by monotherapy, you mean only psychotherapy?
Only psychotherapy.
Gotcha.
And again, by the way, mild to moderate depression, if somebody scored, 5 out of 9 on their depression scale, and then it's not disabling, they can still function, they still go to work or do their basic life, stuff. This is moderate depression. This will respond to psychotherapy. You do not need medication. I would go with that first. When it doesn't respond to psychotherapy, that's when I would try antidepressants, right? Okay. Now, if we had somebody with severe depression and we combined both psychotherapy and antidepressants, see how we picked up much higher number here on the graph. We are achieving over 70% of patients responding. The other one in gray is remission. Remission meaning that you don't have depression anymore. The black one is more of remission, meaning that depressive symptoms decrease by 50%, okay? So that's great news, okay? But the problem is, those who do not respond to antidepressants and psychotherapy, what are we going to do next? So if they failed the first treatment in here and we start, looking into, let's switch to another medication, we fail, we only pick 30% of patients. They don't respond, we go down to 20% of patients. They don't respond, we go to about 16% of patients. By the fourth antidepressant that you try for a patient, the chances of response is 6.9%, right? So the more trials we have, the less chance the next one is going to work out, right? Well, that's medicine, because that's what happens, say, with antibiotics, right? If you're prescribing an antibiotic for a certain infection and it doesn't work out, and you go to the next antibiotic, you had resistance. Those bugs had resistance to the previous medicine. So it's a dilemma that is not unique to mental health. Sometimes we get a little bit of despair that we see from our colleagues in other fields, like, oh, depression is really hard to treat. Well, who said that infectious diseases are not hard to treat?
Right.
Who said cardiovascular diseases are not hard to treat? But those are accepted to spend money and to invest and to kind of talk about it and what have you. But when it comes to mental health, no, it's just in your head. Don't worry.
Right. You're pretending. You get over it. The whole let it go. Let it go. You had trauma as a child. It's still bothering you. Just let it go. But anyway.
Yeah. So then that's where we have to look outside the box of medications, right? We can always, give an SSRI that will increase serotonin in the brain and see if that would help us with what we're doing or not.
Sure.
But one thing that we know, that if we fail the antidepressant, the chances of the next one not working is higher. Number two, even when they work, over time, they could lose effect. And number three is that if they work, they could have side effects as well, right? So some people, especially for ladies, if they put on weight, that could be a reason for them that they don't want to be on medication anymore.
And you know what the one thing men hate about antidepressants
Sexual
is?
side effects.
Exactly.
So,
and that just makes us more depressed.
Yeah, and I see that in real life a lot, right? Like, you have a whole list of side effects to medications, but those two particularly they could cause more depression.
Sure.
The depression that you're trying to treat.
Absolutely.
So then what do we do? Like, how do we deal with this situation? We have to think outside the medication box. And that's where TMS comes to play. Okay. Before TMS, before we had transcranial magnetic stimulation, we used to do ECT or shock therapy, right? It's invasive, it's aggressive. I get it why patients, cannot, have an
Talk
opinion.
about a stigma, right?
Yeah, yeah. So, and I understand it though for ECT, because you are basically not being too specific. You're admitting a patient to a hospital, you're putting them into general sedation as if you're performing a procedure, you're shocking their brain with electricity. It is life-saving for some conditions like catatonia or psychosis.
Sure.
But to use that for depression, a lot of patients do have a little bit of fear of doing ECT, especially that it could cause memory issues. The side effect profile is a little bit large.
Not to mention multiple sedations isn't good
And
either,
Multiple sedations mean exposure to hefty medications, hefty drugs in regular, consistent paces. That by itself could be contributing to the memory issues. So criticism for ECT is huge and it's validated. But hey, we are in 2021 now, right? We have to find a better way to activate the brain without delivering electricity everywhere. Is that possible? And the good news is yes, you can use magnets. Magnets or magnetic pulses could induce microelectrical current inside the brain while penetrating through the skull without causing any problem, and activate that area of the brain directly, not causing issues, right? And magnetic fields are all around us. So we're talking now, I'm using Wi-Fi signal. That's electromagnetic field that is going everywhere. Your cell phone, there is a 5G tower somewhere, if even a mile away sometimes, and that one is sending electromagnetic signal. Your phone is receiving that electromagnetic signal and translating that to microelectrical current that is interpreted as data. That is called Faraday's law. That's what all of this electromagnetic fields is based on. Every magnetic field does have electrical field, and every electrical field has a magnetic field. So if I deliver a magnetic, pulse close to the area of the brain called the dorsolateral prefrontal cortex, which is the forebrain, this is the frontal cortex of the brain, I could activate it to get patients out of depression this way. And this does not require sedation. Patient is completely awake. They're watching usually Netflix, Hulu, YouTube in our clinic, or TV generally. They could be on their phone using one of those, therapy apps. They could be talking with their therapist during their treatment, and they're completely awake during the treatment. That treatment has some tapping sensation on the side of the head, because of the magnet that makes a little bit of a noise in that area, but it doesn't really hurt. It's not like you're getting an electrical shock or anything, so there's no need for sedation. And you have to do it repetitively. So you do it for about 19 minutes every day. You do it 5 days a week for 6 weeks. I usually, when I talk to my patients, I tell them it's similar to if you're going to the gym. Nobody goes to the gym and lift up weight one time and say, hey, I'm done.
Right. The quick fix.
Muscles now, right?
Quick fix USA, as I call it.
Right.
Yeah.
So you lift up weight in sets and you repeat those on daily basis, and you do it for a few weeks. Then you look into the mirror and you get before and after, and you say, hey, I built up the muscles that I was expecting. Now, ideally, you would want to pick up this exercise in a different way. You're not going to work on the same group of muscles all your life, right? You're going to focus on a group of muscles for 6 weeks, and then you move on to something else. Similar thing with TMS. After those 6 weeks of TMS, if you have responded to the treatment, then you continue behavioral activation, enjoying your life, continuing with therapy. I usually try to get my patients back into therapy when they're starting TMS, and usually their answer would be like, what are you talking about? I'm here for TMS because therapy did not work for me. It did not work for you on its own. But if we're doing both at the same time, that would help my magnets work better if you were doing therapy as well at the same time. So it's synergetic effect. And
do you have a slide, or do you have a picture of what somebody getting the procedure looks like?
In a second, I will show it to you.
Great.
This part in here, this is if we're doing TMS on its own. We have a success rate of about 58%. By the way, this 58% is after a patient had failed all of those medications. So that's if you failed 4 antidepressants and then you got TMS, you have 58% response rate. Add therapy to it, it pushes up to 66%.
Wow.
So those with treatment-resistant depression, if they're doing therapy and TMS at the same time, they have higher success rate than if they were doing it, on its own. Let me see if I can make it bigger. That's what I'm talking about in here. TMS plus psychotherapy. It's as good as if you were trying psychotherapy and an antidepressant if you are not treatment-resistant depression. So
And
this
we were even talking about, sorry to interrupt, we were talking the other, when we were doing our pre-interview, that it would be interesting to actually do some exposure therapy while the person is getting the TMS procedures to actually activate whatever part of their brain is being lit up or fed by that trauma.
Absolutely. This is what you're mentioning now is basically the cutting edge now of TMS. So TMS was approved in 2008. So it's not like, was born yesterday or anything. It's been there for a while. And there had been about 3 million sessions of TMS delivered in the United States of America. So it's commonly used. People don't know about it that much, but it's getting better over time. And what you're saying now is exactly what the future is hiding over time. Basically, the idea is that stimulating the brain that is not active about anything might not be as good as if I'm stimulating a brain that is already active in those pathways. So when I'm trying to stimulate this area of the brain, I want it to be its maximum potential activity to get the best effect that I'm looking for. That idea came from the OCD trials. So currently, TMS is approved for depression, OCD, and smoking cessation.
Wow.
For the part of OCD, the idea of it, I want to expose the patient to whatever was provoking their obsessions. Like say somebody is germaphobe and they kind of worry about dirt generally, and I got, the trash can in their lap, right? And they're freaking out, oh my God, it's dirty, I can't do this. That's when we start the treatment. That's when we start, TMS. Why? Because the limbic system circuits that are running with those obsessions in the brain at that time is at maximum activities, and now I can fix it the most that I could. So similar idea could be taken back to depression. Maybe that's why if a brain is going through cognitive behavioral therapy or going through any therapy during TMS will respond better than TMS by on its own. In this image, I have, this is the machine that we use. We have 3 of these machines in our clinic, but that's how the magnetic coil look like, this box in here. And patient will be laying in the chair. It's very comfortable. It's almost zero gravity. So back pain issues like that would not be bothered whatsoever with it. And that, magnet in here will be delivering the magnetic pulses to the patient while they're sitting in here. As you can see, this guy is completely awake, during this treatment. I wish that we could do another stream in the future when we have active patients, so we get a permission from one of the patients to kind of
awesome,
get streamed, live to something of this sort.
And you mentioned too that there may be a couple of your patients who would be interested in coming on and talking about what the experience is like for them.
Absolutely. Beautiful. Absolutely. We'll work on it in the future for sure. And then the last slide, I don't want to bother you with too many slides, and I know you.
No, this is great, man.
Probably have a lot of questions, to kind of, or some questions to kind of answer in here. But let's see if I have one last slide in here. Okay, so this will show you a representation of the changes that happens in the MRI, functional MRI of the brain before and after TMS. So this is a healthy brain on the right side, or after TMS, after successful TMS. When we tag, certain sugar to see what the functional, where the uptake of the brain is happening in an MRI, we can tell what parts of the brain are active and not. So a depressed brain, usually it's hypoactive. It's in a sleeping mode, and mostly because of, obviously we talked about genetics being a component, trauma during childhood, and then stress that the person is exposed to, throughout their life. So when your limbic system is always in this fear or fight and flight reaction, it gets to a disconnection between the limbic system and your cortex, where we actually do the thinking, because you can't handle it anymore. So the cortex becomes hypoactive. When we treat a brain with TMS, it lights up again on a functional MRI. So that's the end result that you're waiting for, at that point. That being said, we don't routinely do functional MRIs except in academic centers.
Sure.
We do the TMS treatment and we track it with the patient's improvement on their own questionnaires and rating scales. We're not treating an image, we're treating the patient, So at the end of the day, it's the patient outcome what matters.
Gotcha.
Yeah.
Wow. Well, let me ask you this. Let's get to some nuts and bolts. So,
Uh-huh.
and we're going to get to everyone's questions. So, please feed us questions and comments. Okay. This is not just about me and Dr. Khaled just talking. Okay. This is about you guys interacting with us. But let's break it down into nuts and bolts. Is this covered by insurance?
Yes, it is covered by insurance. So when it was approved in 2008, insurances were taking their time to investigate. Hey, is there something that we want to do or we don't want to do? This lady, I'm going to give away three books from this book, 3,000 Pulses Later by Martha Rhodes. She's amazing. I've been in touch.
3,000 Pulses Later is the name of the book.
That's the number of magnetic pulses that we give to the patients during their course of TMS.
Wow.
So Martha had went through a lot of struggle to get her TMS approved back in the 2010 era, or around that time when TMS was just coming to real life practice, to kind of get it approved by insurances. But currently, as of 2013, all major insurances cover TMS. It's just that they have a criteria. They would want patient to have tried other treatments before we get to TMS.
Gotcha.
So you have all major insurances, even Medicare, TRICARE, all of those do cover TMS.
Good. And then, so somebody just walk off the street and say, hey, I want this treatment?
If they had tried medications before, yes, you don't need referral.
But if they want to pay cash or if they want to pay...
So that is a big question nowadays, because TMS is not only helping with depression, it's helping with a lot of other things. So for example, it's currently being studied for cognitive enhancement, right? So some people who do have a bit of attention issues, or they want to be smarter or focus more on studying and stuff like that, they're looking into TMS as a solution for that. Now, this is more of an enhancement reason, and I, as a doctor, still don't practice that, and I don't encourage it. I think that when we come up with a creative idea, we have to use it for to treat medical and mental illnesses first, rather than looking at that as enhancement.
Just starting to say, try this TMS to, for whatever.
Well, they are. There are studies. When I went to Duke, to kind of learn about TMS and what have you, there are athletes who are getting TMS and comparing them to their performance before and after on the basketball field.
Wow.
And what have you.
Wow.
You have surgeons who are getting TMS and they're seeing their performance in endoscopic procedures before and after, and seeing how that's affected, and that's promising, obviously. And obviously the military will get on it and stuff of this
sort.
Sure,
and then we'll have the TMS Ultimate Soldier, and right.
Well, we have the NIH running studies now on early Alzheimer's, right? So if it improves cognition, why not doing that for somebody who we know could get Alzheimer's, advanced Alzheimer's in the early stages, and postpone that stage, from happening at some point.
Sure.
So this field is just gonna go and grow over time. This is psychiatry 3.0. We want to make sure that it doesn't jump too many steps unintentionally or inappropriately. So the answer to your question, yes, a person could have depression and say, I don't want to try medications. I just want to go with psychotherapy and TMS right away. If they're paying privately for it, yeah, they can have that. The FDA indication for TMS is failure of one antidepressant in the past.
Okay. And we're going to get to your question. So my last question, and I know we're monopolizing all the time, but my last question is, from your experience, how many, and I'm not asking for a guarantee, but in your experience, how many treatments does it take before somebody can start, wow, I do feel something here?
Yeah, that's an excellent question. And I get about half of my patients asking this question during the initial consultation. So the initial consultation usually is educating the patient as much as possible on an individual level. About half the patients ask this question. So you're telling me the treatment is 30 treatment sessions. When do I see the improvement? Now, per research, the improvement will start, or most responders showed the response by the end of their second week, meaning by the 10th sessions, okay? So 10 sessions, you start seeing improvement. Now, don't give up, though. Continue. It's similar to what we're talking about in the gym, right?
Sure.
If you exercise only for a couple of weeks and you're feeling, you know what, I'm more fit now, I can run a little bit longer, you probably still want to continue to make sure that the muscle mass that you build is going to last long. So we continue all the way through 30 treatment sessions.
Nice.
And sometimes we do something we call taper off. We do 3 sessions in week number 1, 2 sessions in week number 2, and 1 session in week number 3 to make sure that we don't have abrupt discontinuation. So, the gain that you got, with the treatment doesn't go away quickly. But that's an excellent question. But you know why it's an excellent question as well? It's because if the patient, 1/3 of patients will not respond to TMS. That 1/3 of patients who do not respond to TMS, if by their 20th session they were saying, you know what, I'm driving every day, for this treatment, and I'm spending a lot of time, I'm not sure if I want to continue. And it's by their 20th session, I'll say, yeah, okay, I'm all right with that. You can stop. But if they, after 5 sessions, they tell me, you know what, I'm driving every day and I want to stop, I'm like, no, you can't stop yet.
Yeah, exactly.
Give it time. It's not yet.
Bingo. So you're more like a coach too, like a personal trainer. Like, look, build that muscle mass and see where we're at. Okay, excellent. So Samantha, Melissa, I'm sorry, I'm looking at Samantha and then I saw Melissa, but Melissa's asking a little off the topic question, which is good because I'm glad you're here. You're the perfect person to ask this. Melissa's saying, my personal experiences have proven that antidepressants just mask true problems. What are your thoughts about that?
So that speaks to, the failure that I was talking about, with the treatments that we have, and I'm not surprised by that. I got a lot, that's my specialty, is treatment-resistant depression. So almost everybody who walks through my door has a negative experience with antidepressants before. So that doesn't mean that I will become biased over time, because I try to see the full picture. There are still patients who do respond to medications, right? So I cannot bash antidepressants completely, but I completely understand what you're saying. Yes, sometimes antidepressants will cause numbing of your feelings as a side effect.
You don't feel down, but you don't feel up.
But you don't feel anything, right? Yeah, I that expression I used not to like it, but nowadays I'm kind of understanding where it comes from. Patients tells me I felt like a zombie. Zombies don't feel anything. How did you feel like a zombie, right? Like when I get it.
Right.
I get it. Antidepressants sometimes could cause more problems that they could help. Again,
excellent.
That doesn't mean that it doesn't help anyone. It helps, a good chunk of patients, taking antidepressants. And I don't want to sound like I'm telling anyone to stop their medications.
Exactly. And I'm not I've said that many times. I'm not anti-medication. I just think they're way too prescribed. Like we talked about before, they're prescribed by people with no mental health training. And they're oftentimes prescribed by telling the patient, you'll be on this the rest of your life.
Right.
And I keep asking for the longitudinal studies on that.
Right. So that's a good question, by the way, Dr. Walker. This is an excellent one. When somebody is prescribed a medication, one, you immediately have to ask the doctor, what are the alternatives, right? Because it's not really an informed consent if you don't tell the patient the alternatives. When I tell my patients about TMS, I tell them about the alternatives, ECTs, Spravato.
Listen, everybody.
I talk about the other ones, right? So if I'm a general practitioner, and the answer to the question, I'm not sure if somebody guessed it or not, they will win a book. Okay, remember, there's 3,000 pulses later.
Yeah, no, we got a couple of people responded.
The answer to the question of what specialty prescribed antidepressant the most, it's actually general practitioners or family physicians. Family physicians and internal medicine. And by the way, I am both. I am internal medicine and psychiatry. So I did both trainings. But the idea there is that when that general practitioner is prescribing an antidepressant, they have to say the alternative as well, which is, do you want to do cognitive behavioral therapy? Do you want to do interpersonal therapy? Do you want to do DBT, dialectical behavioral therapy? Those are the alternatives, to taking a pill, right? Number 2 is when you prescribe a medication, you have to have a plan to how long you're going to continue.
What? A treatment plan? Come on.
Right. So, your patient, you put them on, I don't know, Zoloft, right? They're doing okay. You continue that for about a year. They're not complaining of depression anymore. Who's going to take this medicine off? You're the one who put them on, right? Like, you have to at least know, when do you consider tapering down this medication and take it off, right? And usually the recommendation after about a year, if the patient is doing fine, we can consider tapering them down gradually. We take them off of this medicine. We see how they're doing. If they get a second depressive episode, we can prescribe an antidepressant again. After the second depressive episode, then we might say, hey, it's going to be lifelong, right? So the problem is, if from the first depressive episode, you put somebody on an antidepressant and you left it forever and you never reconsidered whether you're going to take it off or not, we go back to that example of antibiotics, right?
Sure.
Now, when your patient is had been on a medication for 4 or 5 years when they might only needed it for a year or so, then you might run into trouble of resistance, and then you get into treatment-resistant depression.
Gotcha.
So that's why, asking a good, professional for the appropriate advice would be really important.
Definitely.
That being said, we have a huge shortage of psychiatrists in this country. General practitioners, family physicians, internal medicine doctors have to help, detecting
Absolutely.
depression.
And we don't want to bash our colleagues, but
Right.
because a lot of it is being fed by that
Right.
cultural, quick fix. I want a pill to fix everything, and then the
Right.
providers are just falling into that too.
Absolutely.
Sure.
So,
okay.
And I know this is an aching question. I don't want to take all the time.
No, go for it.
Over this, but it seems to be an important topic for your audience in here. The reason why we prescribed all of these medications is also multifactorial. Part of this is patient wants, quick fix, right? So that's part of it, right? Number two, money, insurances, right? So insurances are going to look, oh, you were telling me that they're going to need 12 sessions of therapy. Oh my God, that's a lot of money. Zoloft is only $4. I'd rather pay for $4, right? And number three is lobbying, so then you have pharmaceutical companies who are coming up with newer medications. They cost thousands of dollars. They lobby with insurances in a way that they end up pushing for more medications to be prescribed because that product is making money, right?
Exactly.
While your product, which is effective, doesn't cause side effects, psychotherapy, right, doesn't make money for the big guy in a pharmaceutical company. And I say that because we have innovation now of trying to go through neuromodulation to help patients with neuropsychiatric disorders, and nobody cares about it. Why? Because it doesn't make money to pharmaceutical companies, right? So pharma is out of the game. Why would they bother? Who cares?
Exactly.
Right?
Exactly. So Jennifer's saying all of my GPs have always suggested I link with a psychiatrist and a therapist. Great. Most of them would continue to prescribe unless I could show them I had done that. Excellent. That's great to hear. Melissa's saying, is it possible to pull yourself out of severe depression alone?
Well, so mild to moderate depression, there had been this look at self-help cognitive behavioral therapy versus cognitive behavioral therapy by a professional, right? And there had been this school when they were thinking, well, maybe if you read Feeling Good, right? That book that everybody kind of praise, for cognitive behavioral therapy, maybe you can get better. But that more, I would advise that maybe for mild cases of depression, if you want to do structured self-help cognitive behavioral therapy, yes. But what is the likelihood of you being able to follow through it? It's just similar to if somebody said, can I get fitness, or can I get fit on my own? Of course you can, but is this going to be as effective as if you had a professional coach who were getting you through that? And the answer is not as likely. So I would recommend that if you don't want to take medications and you want to push through therapy, do it right. Meaning do it with somebody who is professionally trained, Dr. Walker, obviously, but many colleagues of Dr. Walker do the same thing as well. Professionally trained to do cognitive behavioral therapy or other modalities. Licensed to do it, meaning that's regulated. He worries about losing his license, by the way. Meaning
absolutely. There's a body overseeing us as opposed
right.
to,
if you're not licensed, what do you have to worry about, right?
I'm a mental health coach, and now, I hear you. Exactly. Right. And people who watch my live stream know I rail against a lot of the self-help people, but that's a whole nother issue. Yeah. So.
And the last part of that is you need to like that person, right? So I don't like the idea of I'm going for a doctor evaluation. I'm not the one who's evaluating the patient. I want the patient to evaluate me as well, right? Especially when it comes to therapy. Therapy is all about that connection between the patient and the therapist, right? So the more that this connection is built, the better the outcome would be.
Absolutely. Great. And Jen is saying, from YouTube is saying, can you do this treatment and take meds at the same time? And then Jen's following up and saying, so maybe we can do this at the same time. Jen is saying, what do you think? No, that's to hear. Excuse me. Jen is saying, do you accept insurance from Canada? I would totally fly out to do this.
So let's answer the first question, which is medications and TMS. So yes, you can continue your medications while you're going through TMS, and that's what I prefer usually for patients who had been on medications for a while. So patients who come through our door, usually they're on 2 or 3 medications already. Okay, if I stop their medications before we start TMS, they might go into what we call serotonin discontinuation symptoms. When serotonin is depleted from your brain pretty quickly, you could have worsening depressive symptoms, and you could have physical symptoms of serotonin discontinuation. You feel fatigued, tired, flu-like symptoms, muscle aches sometimes, foggy, memory, and what have you. Now, that will make the task of the magnetic stimulation of the brain a little bit tougher, right? And for this reason, I usually don't, you've been on medicines for, 2, 3 years, hold on for another 6 weeks while we're doing TMS. Once you're better with TMS, then we can taper down the medications gradually, not abruptly. We always kind of look into what medicine we're looking at, and we taper it down gradually. So that's what I do with my patients.
Excellent.
The second question was from somebody from Canada. Hi, Canada. By the way, Canada was one of the, Dr. Bloomberg from I think University of Montreal had been a great asset to the improvement of the field of TMS, because in Canada the healthcare system is a little bit different than here. It's not as commercialized. So to provide a treatment, you have to convince the government of the feasibility of such treatment. So they pushed for something called theta burst stimulation. And theta burst stimulation is a shorter period of time on the treatment share. So you can treat multiple patients with the same amount of expenses or what have you, so you decrease the cost. And they run a really big trial in there that actually granted the FDA approval for theta burst stimulation, I think in 2018. But to answer your question, with theta burst stimulation or with TMS, we have a newer protocol where a patient can do the whole treatment in just 1 week. And I usually, have patients from northern states, who, will be coming to Florida for a vacation or something like that, and they want to have their TMS done and squeezed into just 5 days. So this is a possible avenue, but it's not then covered by insurance. Insurances would not cover for accelerated TMS, what we call it. Accelerated TMS, you do about 50 sessions in just 5 days, but that has a really great efficacy. It's in its infancy. It's not yet approved by insurances because they have to review the data behind it before they put it on the list. But it is possible.
Well, if anyone's curious about costs and doing something like that, here's Dr. Khaled's website, and you can check him out and get it. Shoot him an email. One of our longtime listeners, Richard, is saying, he's on with you, and he's calling you DJ Khaled. So he's right there with you.
Yes, it's my name pronounced like DJ Khaled. That is right. Another one.
Exactly. So Dahir is asking, do you ask your patients to exercise as part of treatment and of your treatment plan for mild to moderate depression?
So we aim for behavioral activation, whether this is exercise. Not everybody, can exercise. Like I could be treating somebody with a neurological disorder. Me mentioning exercise is another thing that could, be more of like an unrealistic for them, right? So, but the idea is behavioral activation, and exercise is one of.
What do you mean by behavioral activation? What do you mean by that?
So doing fun things that will bring pleasure to the patient,
as opposed to cognitive behavioral cognitive, meaning you change your behavior, you might actually think better, feel better.
Correct. So obviously this is what you do on daily basis, but the part that I like the most of cognitive behavioral therapy is the task of behavioral activations. Why? Because what I'm doing with TMS is I'm trying to provoke those pleasure and cognitive areas of the brain in the dorsolateral prefrontal cortex that could be activated endogenously. They could happen if the patient is able to enjoy things around them. And that's what we do with CBT, right? We're trying to look at things differently, and then we are trying to bring pleasure actively to us until we feel it, and then we're motivated more to do it over time. So usually I would, me and my staff, what we will try to do is give a patient a list, throughout their treatment of things that, makes them happy and they're easy for them to do. Because what happens with depression? You have no motivation. You don't want to do anything, right? So if I tell you, oh, you like cycling, you should get on the bicycle tomorrow, right? Well, the chain needs to be, greased, and the brakes has to be fixed, and I have to take it to the bike shop and what have you. I'm not going to do that. I'm depressed, right? So then you would not do it. But if I tell you, you know what, how about taking a walk? Is that easy for you? Well, yeah, I can take my dog for a walk, right? Let's start with that. Let's do that on daily basis until you're getting a little bit better with it. Make the walk a little bit longer. Then you can get to the next step in what brings pleasure. The next one after that, go in with a family member for dinner or something like that. Okay, that brought me pleasure. You know what? You're right, Doc. There are some things that are enjoyable in life.
And it doesn't have to be either or,
Right, all the way until we get to the cycling part. So when my patients do that while they're going through TMS, they do what we call facilitating, right? So those circuits in the brain are getting more open, more actively, because we're doing both at the same time.
Excellent. Okay, and so Adam's asking a real world question here. Let's get to this one. One of the biggest problems associated with me is related to anxiety. Whenever there is a panic, whenever there exists a challenge in my work, I always think about the worst case scenarios, and many times panic attack, and that invokes a panic attack. So on a cognitive behavioral level, and then I'll throw it to you. On a cognitive behavioral level, one of the things I would work with Adam on is, what's going on with his fear of failure? What's going on where he'll have a problem at work, and instead of looking for solutions, he's going to go to the worst case scenario in a situation, which is going to then give me some insight into, I wonder if Adam had some trauma as a kid where he was held to perfectionistic standards, where he felt that there was no way that he could ever exist with an issue or a problem without immediately going to, I'm either a winner, I'm a loser. And then we would work on panic attacks and ways to modulate and regulate breathing, and ways to focus on the negative self-talk, feeding that panic. So that's on a cognitive, behavioral, psychodynamic level. What's your take on that from a psychiatric / TMS perspective?
I love it. I love what your approach, and this is the appropriate one, for dealing with generalized anxiety disorder and panic.
Is TMS good for that? Is that for anxiety or general?
So yes, treatment-resistant anxiety could benefit from a different modality or different protocol of TMS, which is on the right side of the brain. So there is a balance between the two hemispheres. So you've probably seen in your practice that about 50% of patients who suffer from anxiety, they do have comorbid depression, and vice versa, right? So there must be a connection between the two, and that's evident by the way that we treat them. Therapy is still the first line treatment for both, right? And then, serotonergic medications are the first line medication, antidepressant, first line medication for both depression and anxiety. Not benzodiazepines, not Xanax and Klonopin and Ativan.
That's why they don't prescribe them in jail anymore.
Right. So the etiology is similar. In the brain circuits, your left hemisphere is the one that drives you, right? This is the one that you have promotion, thinking, I want to achieve this, I want to get that, I want to, whatever, kind
creativity, all that.
Your right hemisphere is the one that has the kind of warning signs in there. That's the one that is, kind of fight or flight kind of center in there. So if it's active on the right side, you feel like, what was his name? I'm sorry, I missed his name.
I believe it's Adam.
Adam. Okay. So you feel like Adam was thinking, right? Oh my God, it's catastrophic. Things are falling apart, right? There's something scary in here. So that's hyperactive. So you could imagine if someone's right hemisphere on the dorsolateral prefrontal cortex is hyperactive, which is activating amygdala and some parts of the limbic system, automatically the left hemisphere is getting suppressed. So that area of the brain, for the promotion is going down. So they're feeling depressed as well. Okay. And vice versa. Patients who do have depression, right? So they're hypoactive on the left. The right side will be more active to dominate what's going on. So they will start getting anxious. So that person started with depression, but they're now anxious to go out with people. They're anxious to do things and stuff of the sort. So when we're looking at neuromodulation, we need to activate the left side to get rid of the depression, and cause hypoactivity on the right side with a different modality of the pulsation that we deliver to help with anxiety.
So it not only activates, but it can also suppress too?
Yeah, so depends on the protocol that you're using. So the protocol we use on the left side is intermittent. It's repetitive transcranial magnetic stimulation. So the machine will sound like an MRI machine. It would go for 4 seconds. It would make a noise like and then it stops for 11 seconds, and then it would do it again for 75 times. So that's the sets in the gym, right? While on the right side, when we're treating an anxiety, the machine will be continuous. Continuous meaning one click a second. So it would be click, click,
Interesting.
click. So that area, because it's clicking and clicking, at some point is going to get tired and it's going to go hypoactive, right? So similar to if somebody was exercising but not stopping, right? Not in sets, right? Those muscles will get tired at some point, and that will cause hypoactivity in that area. So we tailor the treatment according to what symptoms the patient is having, right? And that's when you ask the question of when does the patient see the response? And I told you by the 10th session. So every 10 sessions, I see them again for a full evaluation again. And if my patient was getting better in their depression, but they're still anxious, I add right-sided treatment, to kind of help with the anxiety component, right?
Excellent.
And stuff of this.
Excellent. So we're going to do 2 more questions because somebody's got to get home and help his wife with the kids. So real quick.
Both of us.
Boy, I tell you, my wife's upstairs with our 5-year-old. Like, dude, it's your turn. So Juan is asking a great question here. Hi, doctor. Has there been any research using TMS to treat ADHD or ADD? I've seen studies that say it improves focus.
Yes, that's what we're talking about when we're talking about enhancement, right? So the idea of enhancement came from the studies that were looking at ADD and ADHD. Would insurance cover for it? No, because the level of evidence is not strong enough to get an FDA approval yet. But that is promising initial studies. Give it maybe 5 years or so, and we will be there.
Good. And Janie's asking a great question. I wish we had time. Maybe you can just, quickly hit on this. Can it trigger PTSD symptoms or re-trigger trauma? Have you seen anything there?
No, I had patients who had enhancement in their memory with TMS.
That can flood them a little bit too much, right?
So that brought some of their memory from their childhood or from previous experiences that they had before. For those patients, we usually try to do the right side inhibitory to kind of calm down this trigger alert or this trigger response that they would have. So that will bring the balance again. But I did not have a patient, in particular that TMS made their PTSD worse, or they collapsed their PTSD, or relapsed their PTSD. It's more of the memory could be a little bit more vivid. Gotcha. Some patients will have vivid dreams, during TMS, because most of the regeneration and the neuroplasticity that happens in the brain happens when we are in REM sleep, like when we are asleep. So
neuroplasticity, everybody, is just your neurons and your brain. It's not a hardwired brain; it's a plastic, moldable environment in there.
So the neurons, we now think that we can regenerate neurons, but more important than that,
stunning.
Connecting neurons better. Right?
Stunning, man, stunning. Yeah. So, and Janie, thank you. Janie is a frontline worker on the COVID crisis. So thank you for all your work, Janie. Last question. Yes, absolutely. Kat, Kat's a long-time viewer, participator in our show. She struggles with some pretty significant psychiatric issues with dissociative identity disorder. What are your thoughts there? With TMS or medication or...
I am not aware of good studies that looked into dissociative identity disorder, for the TMS for dissociative identity disorder. And also, we at this time think that if somebody has psychosis or parapsychotic symptoms, we should avoid to do TMS because it's activating treatment anyways, right? And if we're increasing, secondarily, if we increased, dopamine in the brain or serotonin in the brain.
Who knows how that could affect the compartmentalization of all of that?
So there had been some case reports of patients who did have, underlying psychotic disorders that they could become more psychotic with the treatment. And there had been some reports of patients who do have bipolar disorder that they could go manic. That being said, that idea is being revisited today. There had been an FDA breakthrough clearance, for the studying, the investigation of TMS to be used for the treatment of bipolar disorder. It's not yet FDA cleared completely, but it's currently being looked at for the treatment of bipolar. So for dissociative identity disorder, I would not use TMS, quite honestly. Yeah.
Okay, great. Well, my brother, I could go on all night talking about this, and obviously people are loving it. Some of the feedback we're getting is, thank you for all this information. So, we're going to have Dr. Khaled back at some point next month, maybe. And please have your... Yes,
let
please
me leave your audience with one task to see if that would help. if you guys like, this live stream that Dr. Walker just did, try to share it and like it on social media so it reaches as many people as possible.
Definitely.
And if we see that it's above average, then I'm willing to come on again and kind of help answer questions. And you can send your TMS questions to Dr. Walker, from now until the next time that we meet. And I'm more than happy to answer.
Great idea. And if anybody has any questions, they want to talk to you directly, get an email from you, here's your website. Feel free to, engage with Dr. Khaled. You'll have to call him Dr. Bawarshi, but I call him Dr. Khaled. And
DJ Khaled works for me. That's all right.
The next show is going to be him and I doing a comedy routine about the state of political polarization. No, I'm kidding. But anyway, I'm going to let you go. I'm going to close out here. Thank you, Dr. Bawarshi. I really appreciate it. The information was great. It was at a level where everyone can just sink their teeth into it, which is exactly why I'm doing these live streams. We're taking this stigma, this, oh my God, what is mental illness? What is mental health? And we're making it something that everyone can talk about. So thank you. Go home and take care of those kids. And we'll see you again. All right, my brother. Thanks again.
Take care. Bye-bye.
All right, brother. Take care. All right, guys. Well, that was Dr. Bawarshi, psychiatrist, normal guy, normal dude. I don't know about you, but I would feel comfortable talking about him, talking with him about anything. So, remember, these are what mental health practitioners are. Okay, guys, we are normal people. We have a body of training and a body of knowledge to help you work on what you're struggling with. Do not stigmatize yourself, okay? And how you're feeling. Real quick, you're watching us on YouTube, please subscribe, set your notifications when I go live. The more people that subscribe, the more YouTube is going to bump the videos up higher, the more people will get help. So again, I'll see you tomorrow, Thursday night, 9 p.m. East Coast. And those are all the times. All right, guys, this is Dr. Walker signing off. Please, please work on your degree of mental illness. There's nothing wrong with that. We all have it. All right, I'll see you Thursday night.